We are so pleased to have Dr. John Marshall here for our web SIS interview. Dr. John Marshall is a professor of surgery and trauma surgeon and intensivist at the University of Toronto, Canada, and he is the past president and member of the Surgical Infection Society. He's one of the 19 sepsis experts who published in JAMA 2016 the third international consensus definitions for sepsis and septic shock called Sepsis 3.0. Welcome, John.
Thank you very much, Rachel. Great to be here.
Well, we are really happy to have you here. And we wanted to start off with, why do you feel it was important to actually redefine sepsis, something that we've known for the past 2 decades as the old definitions? Why was it important to redefine it now?
Well, our understanding of sepsis has changed profoundly over the past, say, 3 or 4 decades. When I went to medical school, the definition of sepsis was the presence of pus-forming organisms in the bloodstream. And so in the interval, we've understood the importance of the host response. We've understood the biologic processes that mediate that host response. And it follows from that that the terminology that we use is inadequate to really describe the process. And so there's been an evolution in the process of defining sepsis that goes through 3 different consensus conferences, the most recent one being last year's.
And what do you feel were the main problems with the old definition, and how's the new definition actually addressing that?
Well, probably the major one is that the original definition of sepsis suggested it was the host response to infection. Mm-hmm. The problem with that, of course, is that it's good to have a host response to infection, and people normally use the word to describe something that's deleterious to the host. And so the shift in focus from the host response to the consequence of that response, i.e. organ dysfunction, both eliminated a term which people didn't like, which was severe sepsis, and more appropriately defines the syndrome as we recognize it clinically, that it's a patient being sick because of a response to infection, not simply mounting an appropriate physiologic response. That, I think, is probably the major advance with that definition. I think one of the big steps forward with Sepsis 3.0 is the recognition that this is an ongoing iterative process. It's going to be informed by our knowledge about the biology of sepsis. It's going to be informed by debate about what the shortcomings of the current criteria are. And so it's a work in evolution. And I think the next one will be perhaps Sepsis 3.1, perhaps Sepsis 3.11, perhaps Sepsis 4.0. But I think we won't complete the process until we're well into double digits, and probably not even then.
And the the host response is really one of the key things that we're trying to get through.
Absolutely. And the whole concept of sepsis is that disease is a function of the host response, not actually the trigger for that response. One of the challenges with this definition is that it eliminates a concept that we had in the earlier ones, which was the systemic inflammatory response syndrome, because we do know that that same response can occur as a result of non-infectious insults, and we don't really have terminology to describe that anymore. But it might also state that the other thing that the new definition does is it kind of eliminates the idea of excessive inflammation or an inadequate host response, counter anti-inflammation, immunosuppression, and speaks instead of dysregulated, which is a much less value-laden term and doesn't imply a particular kind of response, or doesn't imply that we know what the appropriate response is going to be.
And Dr. Heckerman, what do you think about this? How is this going to impact?
So I'd like you to kind of focus on what are the challenges for the clinician at the bedside, and particularly if you could talk to the extremes of the outpatient sepsis versus a patient in the ICU.
Well, I think the challenges for the clinician are greatest where you have the least amount of information, and that's going to be the outpatient department, the emergency department, perhaps on the clinical ward where there's a little bit more monitoring. In the ICU, I think there are many, many challenges, but they are of a different order of magnitude. And I don't think the current definitions really address that. The issue, I think, for the clinician in the emergency department or on the ward is faced with a patient in whom you're not sure what's going on.
Right.
How worried should you be about the possibility that that patient is going to deteriorate significantly? And number one, and number two, what is the probability that what is causing that is an infection, and that therefore you should be making appropriate microbiologic dose diagnosis and starting antibiotics, source control, etc.
Okay. Now, in the article, you guys focused on the Q-SOFA.
Correct.
So can you comment to the value of the Q-SOFA? How can it be applied to the clinician?
Well, okay, so what Q-SOFA is, it derived from an effort to use data to inform the process of trying to identify criteria that would identify the patient who's at risk of deterioration. And so in a large database of well over 1 million patients, using hospital records from North America and Germany, 3 variables stood out as independently predicting risk of further deterioration, and that was respiratory rate greater than 22, hypotension, and altered mentation. Those are obviously elements of organ dysfunction scores, such as the SOFA score. They are minor degrees of organ dysfunction, but the idea was that perhaps we could brand this as QSOFA or QuickSOFA. We had many other acronyms, some clever, some tortured, but QSOFA was the one that seemed to
that seems like it'll be very easy for a clinician at the bedside to apply quick scoring, to be concerned.
I think it would be a mistake to consider it a score. I think it should be more a prompt, that when you see a patient who's confused, think, aha, is this a manifestation of sepsis, and is there something else going on? Now, the argument against that is that it's quite advanced at the stage that the patient's at when they're confused or hypotensive. And they're quite constrained. So there are many other things that can tell you the patient is on a trajectory towards deterioration, and they're not included in that. And so that's where a lot of the controversy about how the criteria has come from.
Now, one of the big benefits of the old SIRS criteria, or SIRS sepsis, was that it was useful for research tool. What are the benefits or challenges going forward for researchers trying to enroll patients into a sepsis study?
I would argue that the SIRS criteria were next to useless as a research tool. I mean, the SIRS criteria were not actually part of the original definition. They were only grafted on to the concept of systemic inflammatory response syndrome after the meeting, because there was a trial underway and they wanted to enter criteria for the trial. And so they were just made up. They turned out to be 4 of the 12 criteria in Apache 2. So they do predict a patient who is going to be sicker, but they don't tell you anything specific about why they're sick or what's likely to be going on a biochemical basis. Frankly, the QSOFA do not either. They probably identify a sicker patient population, but they don't tell you they don't give you any granularity into why exactly that patient is deteriorating, or what you might do in a clinical trial to modify that. And I think it would be a mistake to conflate what are essentially a prompt, a clinical, flashcard almost, with the entry criteria for a clinical trial.
I think that's very important. Well, on behalf of Surgical Infection Society, we'd like to thank Dr. John Marshall for
Thanks so much.
on the new sepsis criteria.
Thank you.
Thank you so much, Rachel.
Thank you.